Hello and welcome to Ask the Professionals Q&A. My name is Heidi Sittelmeyer and I'm the Director of Online and Community Connections here at the Arthritis Foundation. I facilitate the Live Yes Connect group here in Los Angeles. I'm a patient living with juvenile rheumatoid arthritis persisting into adulthood, osteoarthritis, and a couple of other comorbidities. Ask the Professionals Q&A is a video series where we solicit questions from the arthritis community and then bring in leading experts to help get our questions answered. Today, I have the great pleasure of having Dr. Zora Prasla with us, and she is a pulmonary critical care physician at UCLA. She is originally from Texas and attended medical school as well as completed her internal medicine residency training at UT Southwest Medical Center in Dallas. She then moved to Atlanta, Georgia to complete pulmonary critical care fellowship at Emory University prior to joining the faculty at David Geffen School of Medicine here in Los Angeles. In addition to caring for patients with general pulmonary problems, she also has an interest in seeing patients who have interstitial lung disease, including lung diseases due to autoimmune illnesses. So this really has you be our perfect expert today, because today our topic, we're going to be having you answer questions from our community about all things lung. And they'll also offer some advice on how to keep our pulmonary systems in tip-top shape. So are you ready to start?
Yeah, let's do it.
All right, great. So first question from our community is, what are common lung problems for people who are living with arthritis? Are certain complications more common with specific arthritis types?
Yeah, so that's actually a very good first question. And so I think the best way to kind of answer that is that, first of all, I'll set the stage with the fact that it does kind of matter actually what kind of arthritis you do have in terms of what kinds of lung diseases are, more commonly going to occur with that kind of arthritis. But what I want to talk about a little bit before we get started is, when we're talking about the lungs and when we talk about all these different diseases or lung problems that can happen for patients with arthritis, I do want us to kind of have a picture of what we mean. So, work with me here. So if you can imagine an upside down tree, that's kind of like your lungs, where the tree trunk and the tree branches are your airways. And so, that is one part of the lung. And then you've also got the lung tissue or the parenchyma, which is kind of, where the gas exchange happens. And so that's kind of like the tree leaves portion, if you will. And then the lungs are surrounded by a lining, which we call the pleura. And so, the reason I say this is because any part of that whole system can be impacted by different autoimmune conditions. So I think, the one that we see most commonly is rheumatoid arthritis. And so with rheumatoid arthritis specifically, interstitial lung disease, where you get involvement of both inflammatory and also kind of a scarring, if you will, or a fibrosis, can happen in that lung tissue, in the interstitium, essentially, of the lung. And so that's kind of what we tend to see most often. You may hear the term UIP, or usual interstitial pattern, of pneumonia, and that's different from kind of a more inflammatory pneumonitis or pneumonia that you can get from some of the other autoimmune conditions. So we tend to see ILD kind of most commonly with the rheumatoid arthritis specifically. With RA, with rheumatoid arthritis, you can also sometimes get what we call like a pneumothorax or a fistula, because sometimes patients can develop these nodules in that lung parenchyma, that are called rheumatoid nodules. And, whether that impacts your lung function or not, it's highly variable. For some people, those nodules can go away, particularly sometimes with treatment. And for others, essentially, if those nodules can actually cavitate and can result in a pneumothorax, or what we call a bronchopleural fistula, where there's kind of an abnormal connection between one of the smaller airways and the pleura, or the lining. Some people can have some airway issues. And so sometimes, especially in rheumatoid arthritis, we can actually see upper airway. So when we talk about kind of the lungs and down, that's your lower respiratory tract. And then you have kind of your upper respiratory tract. And so sometimes people can have, involvement of that. Some of the things that we see with some of the other arthritis, so for example, with psoriatic arthritis, we tend to see a little bit more airway involvement. So, things like COPD or an asthma-like picture. You can also get ILD with psoriatic arthritis, but that's definitely more rare. And similarly, you can get a lung disease called sarcoidosis or a similar type of pathogenesis, if you will, with that as well. But again, very rare. And then another common example, or another example would be, and this is pretty rare too, ankylosing spondylitis. So for that, people, as the disease progresses, you can kind of see multiple things happen. So one is that as the kind of the rib cage and the spine kind of fuse, you start to have what we call restriction of the rib cage. Meaning that you can't expand your rib cage totally to get the full capacity of your lungs. So we can see a restriction on our pulmonary function tests. And then sometimes people can actually develop like almost like a pleural scar or fibrosis of the pleura and the parenchyma, kind of that interface, especially in the upper part of the lungs. That eventually can become larger and larger and cystic and can sometimes develop a super infection on top of that. So a very long answer for that question.
We also have multiple types of arthritis that literally fall under artery, right? So.
Right, that's true. Yeah. And then, one other thing, so we talked about the different parts of the lung, and a lot of some autoimmune conditions can also cause inflammation of the lining or the pleura. And so, that's called pleuritis. And so it can cause either pain when you get that, or and then some people can also develop what we call pleural effusions. And so essentially an abnormal accumulation of fluid kind of between that lung tissue and the lining. So all of these things can also occur with certain lung diseases. So for example, the pleural effusions tend to be more common with rheumatoid arthritis. And then for patients who have lupus, they can develop a lot of that inflammation of the lining or pleuritis.
All right, so our next question is, what are the risk factors for lung complications in arthritis?
Yeah. So, generally it depends, I think, again, kind of on the arthritis, but for some of them, especially, so for example, for rheumatoid arthritis, oftentimes age can be, a factor. I think generally for certain kinds of arthritis diseases, having high levels of inflammation in the body can contribute certainly. Anything that is that you're inhaling, so cigarette smoking, any sort of other inhalants, whether that's chemicals, fumes, any of that can also cause kind of an irritation or inflammation in the airways. And so, how do we lower the risk, I guess, if for complications? Definitely smoking cessation or not ever starting is very helpful. Exercise so that you're kind of staying in good condition and kind of using all of your muscles. And I think one of the other things that's important is making sure you're up to date on your vaccinations as well, to kind of protect you as best as you can.
So our next question is, do my medications increase my chances of developing lung complications?
So that is one of the unfortunate side effects of some of the medications. So I think most commonly people hear about methotrexate being the one that kind of everyone thinks about, in terms of being a medication that we use for arthritis treatment, but that really has this known association with having what we call like a drug-induced pneumonitis. So essentially an inflammation of the lung tissue, from the medication itself. The reality is that that's actually fairly rare. It's certainly something that we look for, but it's pretty rare. There's also, in terms of the TNF alpha agents, the tumor necrosis factor agents, there's a lot of controversy about whether or not those actually can exacerbate or even worsen ILD. And so I think that, for a lot of these studies, first of all, we have really small numbers, but second of all, there's so many confounding factors that it's really hard to tease out for this particular medication, this does that, or this causes this problem. I think the one thing that people always ask about is steroids. And so steroids themselves, or I should say that's a very common medication used to treat arthritis and other inflammatory diseases. And so steroids themselves are, from a lung standpoint, not necessarily harmful in and of themselves. I think the concern is more about the infections you can develop while you're on it. And in particular, one that we really worry about as pulmonologists is a fungal infection called PCP or pneumocystis, you may have heard of, or PJP is kind of what we call it now. And so when patients are on, a higher dose of steroids, meaning 20 milligrams or more, and particularly if you're using steroids in conjunction with one of the other kind of immunosuppressing medications, as pulmonologists, we certainly recommend prophylaxis, to prevent any sort of PJP pneumonia on top of that.
So our next question, a related question, is, do complications increase the longer you've been on a medication?
I think that it depends on the medication. So some medications can be dose dependent in terms of the complications, whereas other medications can be duration dependent. And so it really just kind of depends on the medications that you're on. And that's a great question to talk to your rheumatologist or to your pulmonologist about.
So our next question is, how often should I screen for lung disease, and which HCP does that screening?
Yeah, so again, I think, like you mentioned, Heidi, arthritis falls under, there's lots of different types under an umbrella. And so what I would say is that there really aren't consistent guidelines for screening per se in arthritis-related lung disease. So for certain autoimmune conditions like scleroderma or systemic sclerosis, where you can still have, arthralgias and arthritis, for that specifically, we do recommend at least annual screening and perhaps even every 6 months to get pulmonary function tests. I think that if a patient with any sort of arthritis is at high risk, whether that's that you've had symptoms before, or you're on a medication, for example, that might be something that we kind of worry about in terms of the side effects causing lung disease, then for those patients, I think we would recommend at least once a year, if not every 6 months, kind of doing pulmonary function tests. Certainly, I think kind of a clinical exam, meaning trying to figure out if you're having any symptoms and listening to your lungs would be indicated at least annually, if not more often. I think that generally rheumatologists can also, do a lot of the screening particularly, but certainly pulmonologists, we're happy to do that as well, and to follow, patients throughout kind of the years and see.
All right, so our next question from our community is, what are some of the symptoms that people should be aware of? And how can you tell the difference from other respiratory conditions, infections?
Yeah, that's a very good question. I think especially now that we have so much more awareness of, I think, viral and other illnesses, I think it is a little tricky to kind of try to, determine if you've got, I think people are always worried that it's COVID versus something else. Generally, I would say that for the most part, we tend to get, with any sort of lung disease related to arthritis, generally, it'll be something that happens over time. And so if you have, or it'll have a gradual onset for the most part. And so, which also makes it harder to catch, right? Because if you're having incremental changes on a day-to-day or month-to-month basis, sometimes you don't realize you're having problems until, the one time you go on a hike or something. And so things to look out for would be, shortness of breath. You can have it at rest, but even with any sort of exertion. So let's say, going to Costco and going shopping, or, going, climbing a flight of stairs, anything like that. If it starts to cause consistent shortness of breath for you, any sort of chronic cough. And so that would mean, having had a cough for greater than 8 weeks or 2 months is kind of what is considered a chronic cough. Especially also if you have pain when you breathe in, that can be concerning for inflammation of the pleura, and so, or that pleural lining. And so any of those symptoms would be, I think, a little bit different from what you might see, with COVID, where it may be more kind of this fever or like this, runny nose or sore throat. You won't really see that kind of stuff with those kind of symptoms with lung involvement with arthritis. But certainly, I think if something has been persistent for over a couple of months, I think it's certainly worthwhile to have it evaluated.
Great, thank you.
Mm-hmm.
Yes, sometimes we tend to ignore things, right? All right. So our next question is, if a patient is experiencing symptoms, what types of tests are done?
Yeah, so I think, generally what we would start with is, obviously a history and to try to tease out kind of what those symptoms are. But generally, I think if in a patient who has arthritis or autoimmune conditions, I would definitely want to get pulmonary function tests and certainly kind of the full panel of pulmonary function tests. Sometimes I'll start with an X-ray, especially if the symptoms are mild or we're not really convinced that that's what it's going to be. But in the end, if we're looking for lung disease related to autoimmune, the best thing from an imaging standpoint is a high resolution CT scan of the chest, where we can look at the lungs and the airways and and the pleural lining and kind of get an idea of any sort of subtle involvement that there can be.
Great. And you mentioned pulmonary function tests. So how accurate are they? And can results be skewed if someone is in a lot of pain, which limits their breathing capacity?
Yeah, that's a great question. There can be some effort-related variability in pulmonary function testing. Some of you may have gone through pulmonary function tests, and kind of the whole battery of tests looks at when we talk about looking at the pulmonary function, where there's 3 sets of tests essentially that we're doing. What we look at is kind of how the air flows in and out of your lungs to really evaluate if there's any sort of limitation from an airway standpoint. We also look at, the total lung capacity, or how much air really your lungs can hold, or how much volume, I should say, your lungs can hold. And then the third thing that we look at is how well can oxygen get through that lung membrane into your blood, which is kind of the function of the lungs. And so generally those 3 things are things that we look for in the pulmonary function test. So, we're looking at multiple characteristics and putting together a picture. So let's say if you feel that, at one point your one portion of that is limited due to pain or whatever it may be, there are other aspects or characteristics of pulmonary function tests that we kind of take as the whole picture. And on top of that, I would say that, generally we won't make a decision necessarily, at least in terms of initiating treatment for lung disease based on just one pulmonary function test. A lot of times we like to see kind of the trajectory of your lung function as well. So we may get one every 3 months for a couple times. And then if it seems to be changing, we may decide to start treatment based on that. And so it's not just kind of a point in time test.
Perfect. All right. Our next question is, what are common treatments or medications for different types of lung disease?
Yeah, so generally, if we have interstitial lung disease, or ILD we tend to use immunosuppression. So some of the medications. So we'll use steroids, kind of higher doses of steroids to begin with, and then we'll taper that dose down over time. We can also use something called mycophenolate. That may be a medication that you guys may have heard of, which is the brand name is Salsapt, or another medication called azathioprine or Imuran. Sometimes, if ILD or symptoms, not so much symptoms, but if the progression of ILD is not well controlled with that, those medications, we may have to go to using, rituximab or Cytoxan, sometimes, but that tends to be with progressive ILD, despite being on an appropriate dose of the initial immunosuppressants. If there's any sort of fibrosis or scarring that we're seeing in the lungs, there may be a role possibly for using some of these antifibrotic medications. There's 2 that are out there that were really initially developed for idiopathic pulmonary fibrosis, but one of them has now been studied in a couple of different autoimmune conditions. And so, it hasn't been, it's been approved by the FDA for specific kind of fibrosing in autoimmune lung diseases. And so there is that one medication if we need to start that for progressing or for progressive fibrosis. And then generally, if you do tend to have kind of a asthma or COPD like picture or any other airway inflammation type of picture, oftentimes inhalers can be a medication that we turn to as well. So a lot of times people may be on a combination inhaler that has an inhaled steroid in it. and a long-acting version of albuterol, so something like Advair or Symbicort or Brio. These inhalers can be used as well.
Yeah, you see my head shaking in recognition. I use some of those, and I have to use a spacer because I'm a juvenile onset, an older one. So my jaw is recessed, so it helps to get the the medications into rather than the top of the roof of my
Well,
head.
and generally, I actually like spacers. The problem is that all insurance companies, this is off the record, I guess, all insurance companies don't, they won't, which inhaler you can get depends on the insurance company. And so they won't always approve those L-shaped inhalers or the HFAs, but yeah.
All right, so our next question is, does medication that helps lung function and better breathing cause joint pain or any other bone issues? I thought this was an interesting question.
Yeah, it is. Steroids is kind of the thing that you hear about the most. And for when you're on steroids for a long period of time, you can get osteoporosis. And so that's something that we try to be cognizant of, and that's also one of the reasons why we will start people on, you may have heard the word steroid sparing agents, so medications that allow us to kind of come down on the dose of the steroids without lessening the effect of immunosuppression, if you will. But steroids, the biggest thing is the osteoporosis that we worry about. Mycophenolate, which was one of the medications I mentioned, it can, this is relatively rare, but about 10% of patients can have some, or there's a 10% incidence of arthralgias or joint pains, or arthritis. And then something that's very rare that can happen is this, what we call an acute inflammatory syndrome, where people might have the arthralgias and the fever and muscle aches and have an elevated inflammatory marker. I have to say, I haven't really seen much of that, but again, it's kind of a rare incidence. And so those would probably be some of the ones that, I can think of.
Great, thank you. So our next question is, how does COVID-19 affect my risk for lung disease? And if you could talk a little bit about long COVID and the increased risk with that.
Mm-hmm. It's hard. So COVID is still very new, even though we've been dealing with it for over 2 years. And so, I think that all of the research and the data isn't quite foolproof yet, if you will. So I think generally, the question is how does COVID affect my risk for lung disease? Well, I think the issue becomes, some people can have scarring from so if they have significant involvement of COVID, meaning they develop a significant pneumonia, that in and of itself can cause scarring. And so for patients who are already at risk for having, lung disease, that can kind of add on a layer of risk to that. But the other, I think, thing that we don't know enough about is that we do know that COVID causes a lot of cytokine release and inflammation. And so patients who do struggle with arthritis can sometimes have worsening of their symptoms just because they're in just because of all the high levels of inflammatory cytokines and things that are raging through your body, I guess. And so, whether that directly makes your lungs worse, I'm not sure that we can say for sure yet. And then for long COVID, generally what we tend to see, at least in the lungs, people tend to have, shortness of breath with exertion, this feeling of chest tightness and heaviness. And so a lot of times we'll try to treat that with pulmonary rehab or sometimes inhalers to see if they help. I don't know that long COVID necessarily, again, we don't know enough, but I don't know that long COVID necessarily increases the risk of developing lung disease from an autoimmune condition per se,
Great. Next question is, how can someone with lung disease protect themselves from COVID when it doesn't appear to be going away anytime soon?
Yeah, unfortunately, but it's beyond COVID. There's always, there's always flu season, and of course other infections as well. And so, kind of essentially the recommendations that we've kind of heard all along, right? Wearing a mask, especially if you're around someone who's sick or if you're feeling sick. So wearing a mask, particularly in places that are crowded or with poor ventilation. It would be important. Frequent hand washing and sanitizer use, that's helpful as well. And then, of course, trying to make sure that you're, like we talked about earlier, that you're up to date with your vaccines, whether it's for flu or COVID or the pneumonia shot, whatever it may be. Those are kind of the main things I would recommend.
Fantastic. Next question is, how can someone with lung complications safely get back into exercise? And, pulmonary rehab, what are the options out there?
Yeah. So, when I have patients who ask me about restarting exercise when they've had lung disease, I often tell them, listen to your body. So I think it's very smart to kind of start slow and work your way up. But and I think it's okay to push yourself a little bit, but always listen to your body, and do only what you can tolerate, right? So if you start to have dizziness or chest tightness or pain, try not to push yourself too much. Pulmonary rehab is a great program. They're great because, not only do they teach you breathing exercises to kind of improve the lung function and really more so improve the ability for you to do your daily activities, to partake in that. But they also help a lot with stretching exercises and flexibility and just kind of strength training, if you will. And all of that, helps us with our breathing. And then, of course, there's always, in pulmonary rehab, there's always the opportunity to have some counseling, and that you're also doing it in a monitored setting. That said, you can always increase your exercise even without pulmonary rehab. And the other thing I will add is that, especially now with COVID, for a while, a lot of people weren't going to pulmonary rehab. And so you can actually go on YouTube and look up you can Google pulmonary rehab videos or pulmonary rehab exercises. And there's a couple out there that are like a 20-minute or 30-minute program that you can do. It's not supposed to take the place of pulmonary rehab, but it's certainly helpful to have to do at home if you would like.
Great. I know a lot of people who love, finding good
Yeah.
research on YouTube. So
Right.
awesome. Well, we're coming into our last question. So, and this one also is an interesting one that came in. When I am in pain, I tense up and breathe short and shallow. Are there any breathing exercises or tips to help myself to breathe deeply and empty my lungs?
Yeah, that's a great question. So, I would say that some people may have access to, or your doctor may be able to get you what's called an incentive spirometer. And essentially, it's a device that you take a deep breath in, and it helps you kind of open up your lungs. And so that may be something that you find helpful. Diaphragmatic breathing may be helpful as well. So if you lie on your back with your head on a pillow and a pillow under the knees, or you can have your knees bent, and then you put one hand on your chest and one hand on your belly and just breathe in deeply through your nose, allowing both the chest and the belly to expand, and then out through your mouth. And you can kind of cycle through that for a minute and then take rest for 30 seconds and kind of go back and forth. And then I actually, I have a Fitbit, and I've actually found that there are different apps and things out there that can help you with timed breathing, if you will. And so on my Fitbit, there's a way to do some, breathing exercises. And so you can find lots of apps and programs out there that can help you with that. But it's all about kind of taking in the slow, deep breath and really letting your muscles relax, as you do that, which is hard to do, when you're struggling with the pain. But then that's why some of these things can be, these tools can be helpful in, getting your mind off of the pain to some extent, so that you can, expand your lungs and not breathe shallow.
So another final question is, do you have any takeaways for our audience, or, something that as a pulmonologist that you want our community to know about?
I think what I would say is that, it can be very scary, I think, to kind of read up on these lung conditions and what can happen. And, I think what I would say is that the best thing to do is to listen to your body and to just kind of pay attention to symptoms, and if you find that things are have really been occurring or bothering you for some period of time, always just get checked out. A lot of times people don't develop symptoms until the disease has gotten much worse. And so from that standpoint, the sooner you can have it evaluated, the more lung function we can help with. So I would recommend that. And then again, just kind of protecting yourself, especially if you are on a lot of immunosuppressive medications, just trying to make sure, again, that you're vaccinated, that you are wearing a mask when needed, things like that, to really protect yourself. And don't smoke.
Great tips. Yeah, I know even before COVID, I was wearing a mask when I was flying, thanks to one of your colleagues. She impressed that upon me. And so, yeah, those are all really great tips. So thank you so much, Dr. Prasala, for answering our questions and your willingness to dance with the questions that I threw at you. We really appreciate you helping educate our community and providing really some sound advice. So I want to thank everyone for watching this episode of Ask the Professionals, and I invite you to come join the conversation at arthritis.org. The foundation offers a number of awesome programs and services, including our patient education webinars. We have podcasts. We have our connect groups, which are our support groups, the online community where you can jump in 24/7. We have our insights program, and our newest tool in our toolkit is the Vim app, where you can set goals and track your progress over time. So thank you for watching this episode, and visit us at arthritis.org. Thank you so much.